I honestly wouldn't say so because it's so easy as a PA to go from specialty to specialty or do two different specialties simultaneously. Like you can, I've seen PAs work in OB. Hey guys, welcome. Happy Monday. All right, gonna let everybody get in before I start. I'm going to be doing e-shadowing tonight. We don't have a guest for tonight, so it's going to be more of a Q&A, and then I present a case study towards the end. So get ready to ask some questions, and I'll be happy to answer them to the best of my ability. All right, so we'll get started. It's recording, so if you missed a part, you can rewatch it. So we'll jump right into it. If you guys have any questions you want to ask, feel free to either you can come on and ask the question. We can do that, or you can do the Q&A. You submit your question and I'll answer it live. So for those that are coming in, we're doing a Q&A today, and then I'll present a case study about at the halfway mark. So just a chance to catch up, answer any of your questions related to being a PA or the application cycle. And yeah, and then I have a cool case study. If there's a lot of new people, I guess while we wait for questions to come in, I'll just start off by introducing myself. And yeah, so you all probably already know my name is Rodeline Joseph, and I am the host of e-shadowing. I'm a physician assistant. I've been in healthcare for a long time now. I got started as a licensed practical nurse in high school, which I completed in high school, and then I worked in college. And I've been a PA for almost 6 years, since August 2016. I went to Nova Southeastern University for PA school, and for undergrad, I went to the University of Florida. I'm from Fort Lauderdale, Florida, by the way, but I live in Atlanta, Georgia now. What are some first question, what are some community outreach / public health initiatives available for PAs to partake in? Community outreach. One of my favorite forms of community outreach is taking part in a community fair. So if you have like a MA or CNA or any type of just minimal entry-level healthcare experience where you can do vital signs or take vital signs, take blood sugar, all that, talk to patients, or to get experience in talking to patients, I definitely recommend you do a health fair. It's like the best thing ever. I really enjoy community health fairs because that's really a way to, like you said, get in touch with the community, do some community outreach, and especially help the underserved. Those are the ones that tend to go to these health fairs because they're free. And then also educate patients, because oftentimes you might be able to not necessarily diagnose, because you guys can't diagnose, but let them know, bring to attention that, oh, your blood pressure was high, you need to follow up, and give them proper instructions and follow up and resources from these community fairs. So I think taking part in a community fair, one of these wellness events, is just one of the best things that you can do to really get involved with the community and just give back your time to just healthcare as a whole and serving the underserved population. I'm gonna give me a second one, please. My dog is just being a fool. Out. Get out. I'm so sorry, guys. She does not know how to turn down. So yes, definitely taking part in a community fair. I did that. I did a health fair in PA school, actually. I coordinated it, and it was amazing. It was one of the best things I've ever done, and you feel so good after doing something like that. Yeah, so definitely recommend it. She's back in again. How much is volunteering important in CASPA? I don't have many volunteering hours. I think it more so depends on the school that you want to attend, if they put an emphasis on volunteering. So I would look at your schools of choice. how does the day-to-day life of a PA look, and how is it different from a doctor? It's actually very similar to doctors, and it also depends on the specialty that you work in. It all varies. I can tell you about the ER or urgent care, which are also kind of similar. But day to day, in the ER, let's say you clock in, you would basically be at a desk in front of a computer, and you would clock in. Typically from your computer, it's via the software that you use to chart patients. And so like the one I'm used to is Epic. So I'll log into Epic and I'll clock in from there. And once I clock in, I'll see the tracker board. The tracker board basically has a list of all the patients that's in the ER. Basically, you can find all the patients in the hospital from Epic too. But you'll see the tracker for your department. And from there, you can kind of go between tabs of, the department, and then within the department, the rooms and where each patient is. And then there you'll also see patients that are currently in progress, patients that need to be seen, patients that are in the waiting room, just basically the patient status. And so if a patient needs to be seen, then you can then pick up that patient. But as a PA, of course, you would pick up specific patients, but it really depends on where you work. And the level of autonomy, I guess, they give to PAs, it depends. Some hospitals, and not even hospitals, but the recruitment firm that you work for, or I guess the hospital, they may have the PAs, in fast track only, or certain areas of the hospital. So for the most part, we practice pretty autonomously as you get more experience, but the rules and regulations and laws and the way you practice vary so much by state and hospital. So you'll find out as you start working, but typically you will pick up patients. Either way, it just depends on the level of severity of that patient, the ESI level for that patient. So some hospitals may just have you see level 4s and 5s, or if you're new, you may just see level 4s and 5s. Other hospitals are fine with you seeing any and all patients. So yeah, it depends on where you work and that hospital's rules. So then I'll pick up any patient that needs to be seen. I'm pretty comfortable seeing the majority of patients that come through the ER. I would say probably a good 85% of patients that come through the ER, 85%, specifically level 3s. If it's like a level 2, or if it's a crazy level 3, then I'll still pick it up, and then I'll get help from the doctor. So I'll pick up a patient, I'll pick up several patients when I come in, and then I just knock them out. But before that, I'll start with reading about them. I'll open the chart and do a quick run through of their past medical history, past visits, just to give me an idea of what I'm working with. So I'll do that for every patient if I have time. And then of course, one of the first things I do is also look at their vital signs. So the vital signs gives you an idea of how stable or unstable the patient is. And we'll talk more about stable versus unstable when I go into the case study, which if you guys have been following me, that you know about stable versus unstable. So so I'll review their vitals, review their past charts, their history, all of that, just like a quick snapshot before I go into the patient's room. Then I go in, introduce myself, do a HPI, a history of present illness, basically interviewing the patient, find out what's going on with them. And in the HPI, then you do your ROS, review a system, basically asking them pertinent positives and negatives related to the symptoms that they're having. And then you do a physical. So you just boom, 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 ask the patient some questions, take a full look at the patient. And by full, I mean focus in the ER. So it's not the same as family medicine or other specialties where you may have more time to do a full assessment. And even so, a lot of these specialties, they still do a lot of kind of focus stuff, focus to the complaint. Unless it's something more comprehensive or family medicine. But anyway, so you ask the patient questions, you do your physical, and it's going to be a focused physical because you don't have much time, one. And then you're only really wanting to hone in on the issue and really do a physical on what you feel like is important. So if the patient comes in with abdominal pain, you're not really going to do a musculoskeletal exam. You're going to focus on the abdomen or what you think could be causing related to that potential diagnosis or whatever you conjured up in your head could be wrong with the patient. And then so once you do your history and physical, and a part of the history is also, asking their past medical history, family history, social history. Social history includes drug use, alcohol use, a little bit about home family life if it's pertinent, and surgical history, just whatever you think is pertinent, whatever's going to help you. A lot of that stuff may also already be in their chart too. So once you do that, you go, you may see all your other patients, or you'll probably go back to your computer and start putting orders in. So the next step is to put orders in. You're going to put orders for medications, orders for imaging, orders for labs. So I'll just put all of those in at once. I put all my orders in before I do any type of charting, because charting takes forever, and that's like the last thing that I do. So I'll put all my orders in for my patients all at once. In terms of orders, like I said, you put in only pertinent labs, pertinent imaging, and pertinent medications that you feel that the patient needs at the time. And so once you get all your orders in, then you can chart, because while those orders are cooking and you're waiting for them to come back from lab and to see the results, then you could have you could go on to do your I'm sorry, my dog is just throwing me off. Then you can go on to do your notes. I'm going to just slam the door, guys. I'm sorry. I don't know what's wrong with her today. Usually she's quiet. Sorry, guys. So yeah, then you go on to do your notes. And so by the time you're done with your notes, or you may not be done, your stuff starts coming back in. And then when your results start coming back, then that's usually the time that I'll typically need the doctor's help. Because I'm like, okay, this lab shows this, or this imaging shows this. What do you think that I should do? And it's really a lot of more so collaboration and consulting, because I just kind of need a little bit of guidance on just to kind of also cover myself, make sure I'm headed in the right direction. Most of the time, if I feel like a patient needs to be admitted, they agree as well. Or if I feel like a lab or looks suspicious or concerning, they'll be like, yeah, and I'll be like, okay, just to have that extra, added layer of protection or whatever, that, oh, this patient does need to go be admitted. Or so that's typically the time that I'll consult with the physician. So yeah, by then you'll go over your labs, imaging, and then you'll determine the disposition and your differential diagnosis. So you kind of already have differential diagnosis, working in your mind the minute you see the patient or talk to them. But by then you'll really have really kind of hone in on what you think is going on with that patient, and from there determine the disposition. So there's always going to be 3 types of dispositions. Either the patient will be discharged, good, safe to go home, admitted, have to stay in the hospital, or transferred. Hopefully the patient is not expired or does not expire. That's another disposition, I guess. But hopefully it's just those 3: discharged, admitted, or transferred. Transferred basically means that they have to go to another hospital or facility because you're not equipped, or they need more care, or they need a specific specialty or provider that your hospital cannot provide. So for instance, neurosurgery, if a patient, broke their neck or something and needs neurosurgery, then yeah, you would have to transfer them. So once you do that, that's it. You've disposed the patient, you've safely discharged them home, or you've admitted them, or you transferred them, or they're pending transfer. And so that's basically it, a run through of my day. And I just repeat it with every patient. So yes, that was kind of long. But I mean, there's a lot more that goes into that. There's a lot of teamwork. There's a lot of back and forth. There's a lot of just mess, but that gives you the gist of it. All right. What is a great way to answer? What are some of your weaknesses during interviews? I would answer weaknesses in terms of, I would be honest with your weaknesses, but talk it as a more so area that you're working to improve. And always, I would like to also follow weaknesses with not necessarily strength, but with what you're doing to improve that weakness. So if a weakness is that, I guess, I don't know, time management, or always being late. That's my weakness. So yeah, you could say that, you know, I'm working on this by, you know, doing this by setting timers, by, you know, waking up 2 hours earlier to get my face done or so. But yeah, just I would follow up your weaknesses with what you're doing, because if it's a weakness, if it's an area of improvement, you should constantly be working to improve, right? So I guess that's a pointer on how to answer that question. And I wouldn't be like super honest. Like, I mean, I wouldn't say like an outlandish weakness that's just gonna like throw them off. So be honest with it, of course, but don't say anything like crazy, y'all. Yeah. What information do you put on our CASPA application for these sessions? Everything is found on ep80.com in terms of what to put on your CASPA. If you scroll down on ep80.com, you'll see. What is the best way to approach professors, PAs, MDs in order to obtain a recommendation letter? Recommendation letter. That's like having a child, guys. The best way to obtain a recommendation letter is to first build a rapport with that person, and don't build a rapport because you're like, oh, I need a letter recommendation, because then that's kind of using. You want to as I always say, you don't build relationships with people to necessarily, I mean, yeah, it's good to utilize them and you'll have them, especially people that are in positions that you want to get to one day, but you're not gonna just kind of do it just for that per se. You're not gonna say, oh, now I need a letter of recommendation, now I have to ask this person. You should have already had these people, you know, in your back pocket, or these relationships from the minute, you know, you kind of knew you wanted to be a PA. You know, you want to always be building networking and building relationships with people, because beyond the letter of recommendation, like, these people are really going to help you get, you know, to your goals. So don't think of this as like, oh, I'm gonna get a recommendation from that person, because then if you think of it that way, you're gonna get the recommendation, then you're never gonna talk to them again, and then one day you're gonna need them for a job or something, even a job recommendation, or just to get a job, and like you didn't keep contact. So I would really say to really make use of people the right way. So, and really show them you appreciate them and stay in contact with them, because that's important. Especially one of the keys to success is being around people that are better than you, that are in positions that you want to be in one day, right? So if I want to be a PA one day, I'd want to be around PAs all day and learn from PAs and build relationships with PAs. And I'm not gonna just kind of do it when I need to, right? You're gonna do it because you understand the significance of that person, you appreciate that person. And when you do that, when you go in with that type of mindset and you keep in touch with that person and show them that, it's easier to get a letter of recommendation. It's more of like, hey, I need a letter recommendation. Can you send me one? Sure. Rather than having to be super formal and think about it and be like, oh, what if they say no? What if blah, 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 what if? So it's so much easier when you've already built that camaraderie, that rapport. Listen, English was not my first language. Yeah, so it's so much easier when you've already built that rapport with that person. So the best way is to have some solid people in your corner from the get-go. So it's, you know, more like me, like sometimes I'll just text my friends and be like, oh, can you send me a reference? Can you do this? Because we have that relationship. So yeah. And then when you do go to ask them, it's a lot easier, like I said. But if it's not that way, then you kind of have to be more formal and explain to them, you know, the importance of this for you, and hope that they'll say yes. And then of course, it's a lot easier also if this is somebody that you've shadowed or worked with. It's a lot easier to ask for a letter of recommendation. There's some recommendation templates, but I don't like that. I'm all about being genuine and just kind of showing who you are. And so I don't do all them templates and stuff. You can if you want to. How much independence does the PA have regarding treatment, or are there limitations of treatment? What do you mean by treatment? It really all depends. Of course, the PA is not going to have full independence with surgery, but with treatment for what? It depends on the specialty. In terms of procedures, we tend to have a lot of independence. We're not going to do every single procedure, but a lot of times if we learn it and the doctor feels comfortable, they may let us do it if we're like certified to do it. Like if it's, of course, nothing like, it's like where the patient's under general anesthesia and it's like a surgery for the surgeon to do. But many minimally invasive or just basic procedures we can do. But just be more specific on what you mean by treatment. PAs have a wide scope of practice, guys. Is being a mentor a part of an organization such as medicine a form of leadership? I would say being a mentor for anything is a form of leadership, because you are taking on the role to cultivate somebody else and help their path. So I would say, yes, that is a form of leadership. Was it hard to get a job as a PA as a new grad? Yes. I would. What's this? Interlive. Yes, I would say it was hard because I wanted to go into a specific specialty. There were a lot of jobs available, I'm not gonna lie, but not jobs that I wanted to work. So for instance, there were a lot of surgical jobs, and I do not like surgery. I didn't want to go into surgery. And oftentimes, and it also depends on where you live. So it may be easier to get a job in ER up north versus down south where I live. Or it may be easier to get a surgery job down south versus up north. So it really depends on geography. Because in Florida, there were so many surgical jobs that I did not want to do. And you'll find that too, that with surgery, because surgeons are like to train new grads because they're so teachable. So I didn't want to go into surgery. I wanted to go into the ER, and the ER is actually one of the harder specialties to get into. And it's a lot of time it can be who you know, or the right person getting you in the door. Or if geography, some states are okay with new grads versus some that are not, or some hospitals, I should say. But yeah, I basically had to move to work in my dream specialty as a new grad, so it was hard. What is wrong with this creature? Oh, I got more questions. I answered that. Okay, thanks for sharing your process of collecting patient profile. Are there questions that you added to this process post-graduation that gave you great insight on patient medical profile building? We mean profile building, like HPI? I'm not sure how to answer that question. In terms of the HPI, I mean, a lot of it is also like you'll get comfortable as you get experience. It's not like a robot, you're not like always gonna think OPPQRSTA. A lot of it's gonna come naturally to you as you get more comfortable. And then it's gonna kind of like speaking to a friend, I don't know if I would say a friend, but just natural. Like you come, hey, my name is Rodeline. What brings you in today? And then you just start talking to the patient. You get inquisitive. You want to know about what's going on. And because you want to know about what's going on, you're going to ask the right questions, and it's just going to naturally flow. So it's not necessarily me adding to the process, but just me getting comfortable with what to ask, and me also learning more about the different disease process, and knowing what to ask towards that potential differential diagnosis. So that's how it just kind of changes as I got more experience. Oh yeah, thank you. What specialty? I wanted to go into the emergency room. How was the transition working as an LPN to PA? Your experience help a lot? I would say my experience helped more in PA school, not necessarily as a PA, because they're completely different. So as an LPN, I worked at a nursing home, a skilled nursing facility. And okay, my first year, I worked like kind of everywhere. And I think my first or second year, I worked everywhere in the nursing home. And then my third year, I kind of chilled and I worked at the memory unit. Like I worked with the psych and Alzheimer's patients, and it was really chill and it was really cool. And that's when I really learned like all the psych meds and like Aricept, Namenda, Cogentin, Zoloft, Prozac. I learned all those medications. So I would say in terms of being an LPN, it really helped with pharm. I did fail a pharm exam. That was the only exam I failed in PA school, was this pharm exam, but then it ended up being curved and then I passed it. But I didn't really fail anything in PA school. Okay, anyway. So being an LPN really helped with drugs, more so than diseases, because as an LPN, that's really what I did. I passed out medications at the nursing home. So I would see these drugs every day and got used to them, and I would know what they were for. So when I would see them in PA school, like pharm tests, or, when we're doing medical diagnosis, then I would know these drugs. So that's really what it helped with me with the most part, because it's very different. Like an LPN, you're a licensed practical nurse. A PA is a medical provider, so very different. Okay. And I would also say that I kind of, being an LPN, I was just kind of also used to just how healthcare worked in terms of seeing patients, working as a team, being dependent on each other, kind of knowing the flow of, a little idea of the flow of things, even though a skilled nursing facility is very different from a hospital. Why PA and not MD? Because I decided to choose PA versus MD because I would say it aligned more with my career goals, with who I was as a person, and just what I wanted for my life. I think that was the biggest differentiator. I wanted to be out of school. I couldn't see myself being in school for that long and then accruing that much debt. And I just felt like that PA was the better route for me, just to be politically correct. PA was just the better route for me. But yeah, that's really, I hate that PA and not MD question. Which specialties allow easier shifts to other specialties and vice versa? Are there specialties that once one goes on that direction, it may be difficult to shift to something else? I honestly wouldn't say so, because it's so easy as a PA to go from specialty to specialty or do two different specialties simultaneously. Like I've seen PAs work in OB like during the day and then night shift as a PA in the ER. So and that's the great thing about being a PA, because PA to MD. I would also say, because of PA and not MD, of course, the being able to switch specialties, even though I've only been in one specialty really since I've been a PA, but just having that freedom too was also a driving force. So it's really easy to switch specialties, especially once you have that first job and you get trained and you get comfortable with just how medicine works, with seeing patients, with treating, diagnosing, just everything. Like once you just build that comfort level, it's so easy to go from say family medicine to ER. I'm not gonna say it's so easy, but it's simpler. Like you really kind of just have to refresh yourself on some of the medicine, and that's really it. And then like the politics of that hospital or facility, and working, and then the EMR system. But in terms of just I don't know, I would just say it's easier. It's fine too, like especially if you start off into specialties, if you start off working in your you get jobs in 2 different specialties as a new grad, that's going to be super great because, you know, you're just always in 2 different specialties and you getting that great training. So I don't think it's very hard. I mean, I kind of in 2 specialties, urgent care and the ER, even though urgent care is very, very similar to the ER. But I think the beauty of being a PA is that we're trained as generalists and we're just kind of trained to be able to move that way, to adapt quickly and go where we're needed. And because you got to think about, like, look at COVID, look at when COVID happened, how many ERs, I keep saying ER, look at when COVID happened, how many PAs were able to go from, you know, being in the ICU to being in the ER to being in internal medicine, just kind of go where they're needed, and how easy it was for us to do that. So I think the beauty of being a PA, and maybe it's cultivated while you're in PA school, is just having that that adaptability and acclimating so quickly. Like, it ain't for everybody, but the ones that do it, like us PAs, like, we do it well. So I've never met a PA that's just like, let me go, go and make it do what it do. I'm so goofy, y'all. Okay. How can you obtain a role on MedSembly? So once you get into PA school, you can then mentor students on MedSembly. So, and of course, with mentor in terms of what you're comfortable with mentoring and helping students with. Is there anything in the PA profession / healthcare that you think should be different? Definitely, not necessarily the PA profession, but definitely healthcare. There's so much politics in healthcare, and a lot of stuff is determined, you know, by insurance, whether the patient can pay for it, whether insurance can pay for it, whether insurance is going to allow it, you know, this, that, and I just don't agree with it. I don't feel like so much should, like, back and forth should go on when it has to do with somebody's well-being and health, back and forth in terms of, like, these insurance company prior authorization, oh, insurance won't pay for my insulin, insurance won't pay for this. Like, that's one of the things I don't like about healthcare, the business aspect of it. I don't think somebody's life should be a business. Did you encounter any questions on your PA apps that ask you your regional connection to the area? No. Regional connection, is it like volunteer work that you did, like, to that area, or like how you remain active in the region? I've never been asked that question on my applications. I've never been asked that. How did you become an LPN in high school? Good question. So I went to Blanche Ely High School. I'm answering these last, let's see, 1, 2, 3, 4 questions, guys, and then we'll move on to the case study. I hope you guys are enjoying this and my zany personality. So I went to Blanche Ely High School, guys. It's a magnet school in Pompano Beach, Florida, and they have a nursing program. So the point of the nursing program is to train you to be a licensed practical nurse. It was completely free, offered by that high school, and of course it was very competitive. Not everybody got in. You had to complete all your high school classes by your junior year, because in senior year was just straight nursing, and it was very rigorous. So I got into the nursing program. I started my senior year, going into my senior year, like the whole summer I was in school. And then that's how I got in, because my high school offered that program. And when you graduate, you can take your board, your LPN, your NCLEX, and become an LPN. So after I did that, after I graduated, I went to UF that summer. I studied for my boards for like 6 weeks. And then after summer A at UF, I went back home, took my exam, my NCLEX, and I passed it. And then I worked throughout college as a licensed practical nurse in the nursing home. What was your typical study schedule or school schedule like in PA school? So I'd be in class all day, every day, my whole life. Literally, I'd be in class from like 8 until like 5:30. And then I get home, I would go to the gym. I try to go to the gym for an hour, then I, get back home. And then I would study the rest of the night. I would probably study from like 7 o'clock until midnight or 1 o'clock every single day. There wasn't a day that I was not studying. I kid you not. Unless I had to like go home or go on vacation or something, which wasn't often. I wasn't the type that ever took a break. I mean, because I was always kind of taking breaks, I would study and then be on Instagram or something, be on social media, then relax and get back to studying. So that's just how I operate. Because some people they'll say, oh, Tuesday's my day of no studying, or Friday's my day of no studying at all. I recommend you do that. Do what works for you, honestly. If you, want to study every day, but take breaks in between, okay, but just as long as that works for you and you're not burnt out. If you need a whole day to yourself, do that. So what worked for me was kind of studying every day, or at least looking over something every day. So that's what I did. And then I would study everything 3 times. So I say this all the time about the rule of 3s. So I would first go over the PowerPoint, very long, then I would go over notes, like physical, like switches through notes, like the notes I would get from my classmates or they got from the prior class. So they were like pre-written notes, and I would write down, I would like do the notes, like write stuff on the notes as I go over the PowerPoints. And then I would go over the notes, like actually read all of them. And then I would make my Quizlet cards. I was notorious for Quizlet. I was like the Quizlet queen because I'm a very fast typer and I can make Quizlet cards. I can do like 100 cards in like 30 minutes. I kid you not. So I used to do all my Quizlet cards, and I would go over my Quizlet cards 3 times. So I would do my PowerPoints, PowerPoints, notes, Quizlet. That's how I studied. And it worked for me. And I got like mainly A's in PA school. And not to brag. So that was didactic. There was a time in didactic where we left at like 6 or 7 p.m., but I think it was because we had a late lecture. I remember it was like the OB lecture. I think the lecturer came, had to do it late because I think she had work or something, and we left late that day. But usually we leave by like 5:30-ish. Unless we had like OSCEs or something to do. But you're in school for, the whole day, every day. And then finals week is like 20 tests a week. I'm exaggerating, but it felt like that. But yeah. All right. Answer that. How long do we have for pre-req classes before applying to PA school until we have to retake them? Oh, yeah, like this person said, like Lori said, it depends on your school. When I was applying to PA school, there was like a 10-year grace period. So if it was more than 10 years and you have to retake the classes, I didn't have to retake any classes. Some schools have like 5 years, which is like crazy. But I'm hoping that for you guys it's just 10 years. Some schools have it to where if you do something or if you got a master's degree, then you don't have to. But yeah, it really just depends on the school. Sorry, I joined late, so hopefully this wasn't addressed already, but how did you approach your personal statement? My personal statement, how did I approach it? I just kind of talked from the heart and really talked about what made me who I am. And much of what made me who I am was actually Blanchard High School, my high school, and being able to do the nursing program that completely shifted my whole life, the trajectory of my life, because I did LPN and I got introduced into healthcare. And then from getting introduced into healthcare, I worked at a nursing home. If I didn't work at a nursing home, I wouldn't have learned about the PA career, or would have learned about it later in life or something. I don't know. And then from being introduced to the PA career at the nursing home, I learned about PA and became a PA. And from becoming a PA, I, now do this and am a PA and work in the ER and all of that. So it really, I got down to the root of like, why is this my life now? Or why do I want to do this now? What was the root of it? Like, what was that, like that spark? And that spark for me was Blanchie Lee High School, my high school. So I started my essay off with that, which was being introduced to nursing and how that really impacted me. So I would start off with what was that spark? What really shifted your life? A lot of students talk about injuries, talk about, family members, being in healthcare, or, family members dying, family members being ill, and, being introduced to PA or healthcare that way. So it's really something personal to you, or it's going to be something personal to you. And that was for me. And FYI, I wrote my personal statement or edited like, it felt like 15 times, but it was probably 4 or 5 times. I had a lot of people review it. I had a PA student. I had my friend who was like super duper smart. I reviewed it. I think I had like 2 friends and a PA student review it. I definitely recommend at least a PA student or a PAC review your personal statement. I'm not really big on like just people who aren't PAs, because they got into PA school, so they know what should be in a personal statement to get in PA school. So that's why I recommend a PAC or a PAS. At least one. You can have other people, but at least one be a PAC or a PAS, because I feel like they know, and you want it from somebody that knows. And having the PAS review mine was amazing. Okay, last question. How do you answer if a patient asks that they want to see a doctor? Man, I let them see the doctor. Just kidding. I do, but a lot of that is ignorance, just not knowing about the PA career, which is, you're gonna run into that. So I always introduce myself, but I'll then explain to them what a PA is, our scope of practice, the things that I can do, and how a doctor is available, who the doctor might be busy, and that's why there are PAs, nurse practitioners available to fill that gap and provide care to the growing population. So I would explain to them that way. And if they still want to see the doctor, okay, you just probably gonna have to wait. Well, you're gonna be all nice. Yeah. Alrighty, so guys, I'll answer any remaining questions at the end. Okay, if you guys have questions about personal statements, I can send you guys my personal statement if you want to like something to review. So this is my email if you want my personal statement. If you need something to like for inspiration, but don't copy my personal statement because they're gonna know and I'm gonna know. All right, I'm gonna share my screen. Okay, this is my screen shared. Okay, so today we're going to do a case study, an ER case study. This is gonna be a pretty easy one. I would love if you guys put your answers in the chat and be interactive. Okay, if you're new, this is how I talk about the ER. One of the most important things about the ER is the fact that it's an emergency room. So if you think of emergency, you think of like worst case scenario, somebody's dying, somebody needs emergent care. So that's how you kind of have to treat ERs. And it's the truth of the matter is it's not always going to be like that. There's going to be people that aren't really sick, really emergently sick, but you still have to treat every case that way, because you might have a patient that comes in looking just like me, looking super duper fine, literally and figuratively. I'm so sorry, guys. I'm so sorry. No, but they look fine, like nothing's wrong with them, but they could be a walking time machine, a walking bomb, like ticking time bomb. I've seen patients like that. Like I had a guy, he looked perfectly fine, like nothing. And he had like a GFR of like 6 and needed like emergent dialysis. So just treat every patient like it's worse first. And I don't mean by ordering everything, but asking the proper questions and ruling the worst case scenario out. That's basically what this means. And that's just, if you approach the ER like that, you're gonna be fine. Ask the right questions, do your due diligence, make sure that you can go home and sleep at night. Okay, so this case study is called It Burns. A 25-year-old female presents with complaint of burning on urination and urinary frequency times 4 days. So you're gonna get this chief complaint. You're gonna pick this patient up. So what are some things that you're gonna do based on what I said earlier? What are some things that you guys are gonna do? You can just write it in the chat. What are some things like that like I said before, that you need to do when you pick up a patient or to see the chief complaint? What would you do next with this? And given what you see the vitals, you open her chart up, or you saw the vitals on the tracker. What's next? I don't know if you guys are. Oh, I see. Okay, I see that you guys are answering. Okay, never mind. I can't see your email. Here, let me try writing it again. Oh, I didn't send it to everyone. My bad, guys. Ah! And this is the, okay. Okay, so good answer. Check their vitals, rule out any immediate threats, history. The chat is disabled. Could you open it up, please? And thank you. I don't even know how to open up the chat. How do I open the chat? Okay, if the chat is disabled, just write it in the Q&A. I see the Q&As. Physical exam, good job, good job. So you're all saying the right things. So you see this this chief complaint, you see these vitals. So based on the vitals, is this a patient that's stable or unstable? Do you guys know what stable versus unstable means? Is this a patient that's stable or unstable based on just what you know? For now, stable, unstable can change at any point during the visit, even if they're about to be discharged. Stable, stable, stable. Good job, guys. Perfect. So from what you see, this patient is pretty much stable. Her vitals look good. She doesn't have a fever. She's not tachycardic or bradycardic. She's not hyperventilating or anything. Her respiratory is fine. She's not in any distress. She's not in any respiratory distress. She's having some burning when she pees. So what are some questions that you'd want to know based on this chief complaint? What are you going to ask? Is she sexually active? Yes, good job. Sexual history, yes. Does she have history of UTI? Yes, you'll want to know about past medical history. So you'll ask, so she's been having the symptoms for 4 days. So questions you can ask is that, so the symptoms started 4 days ago. So she says she's having burning when she urinates and urinating a lot. You can ask, does she have any blood in the urine? Does she have any vaginal discharge? Does she have any itching? When was her last menstrual period? Does she have history of UTIs? Any other associated symptoms like abdominal pain, nausea, vomiting, diarrhea, fever? So those are important questions you want to ask about those type of symptoms or that she's having. And I'm glad that you guys realize that being that she's having these symptoms, you're not just going to think about urinary, you're also going to think about STIs and reproductive disorders. Because she's a female, not because she's a female, but because she's young, she's having these symptoms, and she's a female, so you have to ask associated questions relating to STIs, like vaginal discharge, like history of STIs, recent sexual activity, unprotected sex, yes. And then, Good. So you're all asking the right questions. So she says no to everything. Symptoms started 4 days ago. It's been burning when she pees. She's peeing a lot. No blood in the urine. Her last menstrual period was a week ago. She's in a monogamous relationship. Gets tested regularly, and that's it. No past medical problems. No history of STIs. No frequent UTIs. All that is negative. And then, so what's next, guys? So you do your focus history. So next you want to do your focus physical. So based on her chief complaint, what are you going to examine? based on her chief abdominal exam. Good job. Yes, you're going to do an abdominal exam. GI, yes, great job. So you're going to palpate her abdomen, because those abdominal, that abdominal area, that's where you find a lot of organs, including the bladder, including the reproductive parts. So you have to palpate her belly, see if she's having pain in any specific area. Because, palpate her belly, do a check for CVA tenderness. Because if she's having UTI symptoms, who's to say that it's not progressing to now pyelo, which is now affecting the kidneys? So you have to do a proper exam. Pelvic exam, good job. Dispa, I'm sorry if I mispronounce your name, but pelvic exam is very important in this person. So in the pelvic exam, if she says she's having vaginal discharge, I would definitely do it. And if she says she's concerned for STDs, I would definitely do it. Sometimes I would probably just go ahead and do it, especially given her age. So a pelvic exam, so you're not gonna just limit to the abdominal exam, but add a pelvic exam with it, just to make sure that her cervix looks fine, that there's not any STDs going on, that she doesn't have any crazy discharge. And with every pelvic exam, I always do the gonorrhea, chlamydia swabs and the wet mount. So the gonorrhea, chlamydia, they're like one of the most common STDs. And we test, those are really what we test for in terms of STDs in the ER. When patients come in, we tell them everything else. They can go to their health department or primary care doctor. We try not to test for every single thing like HIV, HSV, all that. We really do gonorrhea, chlamydia. We do the swabs, and then we do a wet mount. The wet mount has BV, which is bacterial vaginosis, trichomonas, which is an STD, and Candida, which is a yeast infection. Trichomonas is the STD, is the only one that's an STD out of those three. Yes, somebody said especially if the kidneys are tender, right? Okay, so now you've done your history. You went and you saw this patient, you talked to her, you did your history, you did your physical. Her physical is benign. She doesn't have any CVA tenderness. What do you do next? Remember I said after I see all my patients, I go back to the computer and I put in orders. So what are you gonna put in? What are you gonna order for? UA, good job. Tell me all the orders you guys are gonna do. All right, UA, CBC, ultrasound, UA, blood test, STIs, pregnancy test. Okay, good job. So what I would do in terms of this patient is you're gonna let your history and physical and vitals guide you, right? It's gonna tell you what to order for the patient. So say everything is normal. She's not tender, her belly's not soft and non-tender. She's not febrile. She only has this burning. And you did a pelvic exam. Pelvic exam looks good. She has no vaginal discharge. Her os is closed. She has no cervical motion tenderness, no strawberry cervix, none of that. So what I would order is a UA. I would do a pregnancy test as well. And I would as I told you guys on the pelvic exam, I would do a gonorrhea, chlamydia swab and also the wet mount. But this patient, excuse me, I don't feel like this patient needs a CBC or a CMP or anything else, because what is that going to tell you? Like, you have to order things that you feel are indicated, right? So do you think a CBC is indicated if she's not really having abdominal pain? What is the CBC going to show? It might show her white counts a little high, but if she has a UTI, it could be high. So I would do a CBC. I would do a full labs and stuff if she had abdominal pain or CVA tenderness or fever, or she didn't look well. But for this patient that just has these mild symptoms, mild complaints, and her exam's completely normal, I would just start off with just the UA. And a UA is going to tell you if she has a UTI or not. And I would also do the swabs for gonorrhea, chlamydia, and for the wet mount. because then that's going to tell you she has an STD or if she has like a bacterial vaginosis or a vaginitis. Other than that, like, I think you'll cover all your bases because she has burning on urination and urinary frequency. And those are the only symptoms that she has, and that's pointing to a UTI. And the UA is going to show she has a UTI. And all the other labs are really unnecessary. But so this, I wouldn't do a CBC or CMP or anything like that. Yeah, you'll send the urine for a culture. Yeah, see, pregnancy test, yes. But so say this patient was not 25. Say this patient was 89. Then what would you do? Say it was an 89-year-old female and not a 25-year-old female. Then what would you do? No GC code. Yeah, heck yeah, you wouldn't do that. Yeah, so you wouldn't need that. But what else? Like, I wouldn't do an ultrasound. I wouldn't do an ultrasound on this girl. She's not having any pelvic pain. Okay, but say she was 89 and not 25, or 85 or 95 and not 25. How would that change the course or what you order? No pregnancy test. Heck yeah, no pregnancy test, I would hope. Okay, but you guys gotta think a little bit more critically. Would you do more? Would you do less? Check for broken bones. No. Remember I said that this patient just has a UTI, really? I think that's all that's going on with her. I don't think she needs more. So you gotta think that with the elderly, you know, they're more sickly. They're gonna have this 25-year-old female, if she says that nothing's going on with her in terms of past medical history, more than likely nothing's going on with her. She's gonna be a perfectly healthy 25-year-old female. As opposed to an 89-year-old, they may have everything under the sun already just because, you know, they're 89 and their body ain't what it used to be, right? So they're going to be more at risk for certain conditions. They may be more at risk for sepsis, for a bad infection. Their vitals may be more off. So that tells you that if it's an older patient, they're going to need a little bit more. So as opposed to just doing a urine test in pregnancy and GC, an older adult, I would add a CBC, I would add a CMP, I would make sure that she's not in renal failure, I would make sure that she's not possibly septic, I would add maybe blood cultures, especially if they have history of UTIs, I would maybe do a CAT scan to make sure it's not going up to the kidneys, you know? So this just tells you that really, look at the type of patient that you have as well, their medical history, what their could become, their propensity for, you know, being at risk for other conditions, being at risk for, you know, it getting out of control. So, right. So you would definitely do labs. Yeah, exactly. Other things will be warranted. Yeah, you should do more of the CBC. Yes. You wouldn't check for cancer, not in the ER. But I mean, it can show cancer, but you wouldn't, it's not something you check for. So yeah, so definitely, you know, in the elderly, it's the workup you do is going to be completely different for a younger patient. So that was just why I asked you guys that. Okay, so her labs come back and she has a lot of bacteria. She had a lot of leukocytes, these little, a lot of nitrites. Leukocytes are like white blood cells. Nitrites are the byproducts. Yeah, leukocytes are the bacteria. They're all pointing to UTI. Like these are all signs. Oh, I'm sorry, guys. These are all signs that a UTI is going on. So especially WBCs and bacteria in the urine, leukocytes and nitrites can be there, and sometimes it can be like a contaminant. And then you'll look for epithelial cells too. Epithelial cells would be pointing to like contaminations. So yes. So if she has leukocytes, if she has WBCs, nitrites, bacteria, RBCs, that's signs of a UTI. Will the PA program expect us to know all this on our interviews? No. No, you're not expected to know any of this stuff. This is just to like get some fun and prep. Prep you for what's to come. To image or not image, do you guys think she needs imaging or no? No imaging. Good job. Did you see that already? So the only time you'll image for a UTI is if you suspect pyelonephritis. So that if your blood tests come back crazy, or if the patient looks sick or uncomfortable, or their physical exam reveals something, or if their vitals are looking crazy, then you want to think pyelo and make sure it's not sepsis. Yeah, or if you're concerned for something going on in your belly, like appendicitis. So yeah, so that's the only time that I would do imaging on a patient like this. And if they bounce back, I've had patients with UTIs, if they come back to the ER complaining of like persistent symptoms, and you would think that it's progressing to pyelo, or you would then do labs and imaging. Okay, so we talked about urinary tract infections already. A urinary tract infection can occur anywhere in the urinary tract. That's why it's called a urinary tract infection. Women are more prone to urinary tract infections because of their anatomy. And a lot of the readings say that at least one woman's going to get a UTI in her lifetime. So, and it's a UTI is not an STD. You're not going to treat them like that. Symptoms may be a little similar. So, especially if they're young women, you'll rule it out like we did. But doesn't mean that she has an STD. You'll tell the patient that too, because they'll be confused. Oh, yes. Alrighty, guys. So we are, okay, so we talked about the UTI and now the treatment for UTI. So, oh, what did I do? I'm sorry, guys. Okay, so the treatment is going to be antibiotics, and it depends on which antibiotic you tend to use. And a lot of times it can depend on if the patient recently had a UTI. So if it's been within 3 months, you're not going to use the same antibiotic. But you'll basically look it up to see, you can look up on Up to Date or Epocrates on first line. You'll know all the first lines like Macrobid, Bactrim. So there's certain medications you can just look up and prescribe to the patient to treat their UTIs. And so, yeah, so patients will be able to go home for the most part on these antibiotics that I was telling you guys about. And you would only admit a patient if they look septic, if you suspect pyelo, or if they're not looking well, if their vitals are looking crazy and you're concerned about them. But other than that, UTIs are fairly, easy to treat, and you'll just do a culture, and you'll send it off for a culture and wait for the culture and sensitivity report to come back and make sure that they're on the right antibiotic. And if they're not, you'll just call them and change their prescriptions. Alrighty, that is about it. So that's the end of the session. So just to wrap it up, I always say to know what's common, know zebras, know what's going to kill you. So know what's common, like your hypertensions, your asthmas, your diabetes. Know zebras in terms of just knowing when to spot them. You don't have to know all about them, like things you'll never see, but kind of have to have a little index of suspicion for. And then know what can kill you, like your heart attacks, your strokes, your PEs, and document, live Pearl. So that is about it. You guys have my email. We have another session starting soon, so I can't stay too long, but you have my email on how to reach out to me at MedSembly and at MedSembly or medsembly.com, guys. So have a nice night, guys. Bye.